Good afternoon, and welcome to the California Healthcare Foundation's webinar briefing, Why Primary Care Matters. My name is Catherine Phillips, and I'll be serving as moderator for today's briefing. I'm a senior program officer at the California Healthcare Foundation and lead the foundation's efforts to advance primary care. As many of you know, CHCF is dedicated to improving access to care for Medi-Cal members, improving the experience of care for all Californians, and particularly people of color, and improving health outcomes for both individuals and populations who are not served well by the status quo. So why do we care so much about primary care? Well, primary care is the foundation, the bedrock of all high-performing health care systems worldwide. And we believe it's the pathway to achieving health equity and affordability in California, two of our state's most urgent healthcare priorities. In 2021, the foundation launched Primary Care Matters, a resource collection to inform decision makers about the need to strengthen primary care capabilities and to increase investments in primary care. I'd encourage you to review that collection. We'll put a link in the chat box to the right of you right now. We also convene California's leading purchasers to align and coordinate their efforts to strengthen primary care. And while California was not first among states to recognize the need to revitalize primary care, it has certainly emerged as a leader in this work, and it's using a pioneering approach. We now have a statewide requirement to track, report, and ultimately increase investments in primary care through our new Office of Healthcare Affordability. And we have voluntary action from leading health plans organized by the California Quality Collaborative and the Integrated Healthcare Association. You're going to hear more about these and other efforts throughout our session today. We're going to begin our session with a presentation from Diane Rittenhouse, who is a family physician, senior fellow at Mathematica. She's an expert on primary care education, payment, and policy, and is going to help educate us about the unique functions of primary care and the very real threats it faces, including a shrinking workforce. Diane will also highlight some key findings from a paper we commissioned on the evidence linking primary care to improved equity and reduced disparities. You can download the executive summary to that paper on the events page you received today. The full paper will be available in January. After Diane finishes her presentation, we're going to hear from a panel of reactors. Paula Barberia, the Chief Quality Officer and Deputy Director of Quality and Population Health Management at the California Department of Healthcare Services. For our national listeners, that's our state Medicaid program. And from Alice Chen, Chief Medical Officer of Covered California. Pallav and Alice will share their perspectives as purchasers of healthcare. Nina Birnbaum, who's the Medical Director for Innovation Acceleration at Blue Shield of California, will share her perspective as a health plan leader. We'll have some conversation and then welcome in Anthony Wright, who's Executive Director of Health Access, California's leading healthcare consumer advocacy coalition. And he'll share the consumer perspective and some promising state actions. We're also going to ask for his assessment of what more is needed to assure that all Californians have access to high quality primary care. We're planning on a dynamic and I hope quite candid conversation about the promise of primary care and the challenges we face in rebuilding our state's primary care workforce, as well as some innovative solutions being tested in the field. Please enter your questions as we go in the Q&A box. We'll save these and have plenty of time at the end of our session for audience discussion. Two quick notes before we begin. We are recording the session. It'll be available on the CHCF website right after Thanksgiving. We will email it to you and we encourage you to share it with your networks. Please also save a minute at the end of our session today to complete a very short event survey. This helps us plan future programming and improve our programming. So with that, let me hand it to Dr. Rittenhouse. Diane, please go ahead.
Thank you, Catherine. I'm so pleased to be here and to be able to contribute to this very important conversation in California. We're going to talk about primary care matters, and to begin, next slide, I want to talk for those who are less familiar with what is high quality primary care, let's just do a little bit of level setting for everybody. So the people who deliver primary care are primary care clinicians trained in generalist specialties. So they take care of the patient very generally. So not only one system of say the cardiologist or the nephrologist or the immunologist might take care of a certain body system, but they take care of the patient from across the lifespan in a broad way. So the kinds of clinicians that we see doing this that are trained are family medicine, general pediatricians, general internal medicine physicians, and geriatricians who care for older adults. Nurse practitioners also can be trained in family, geriatric, and pediatric care. Now, not all of the people in, for example, pediatrics or internal medicine go on to practice general primary care, but many of them do, and that's the group we're talking about today. These clinicians do not work alone. Increasingly, we're seeing these clinicians working with a team of individuals that help them deliver primary care. And that can include nurses, medical assistants, community health workers, behavioral health counselors, depending on what kind of practice you go to, what kind of clinic you might see or healthcare system you might see a primary care provider in. You'll run into various members of the primary care team. Next slide. So what's unique about primary care? What are some of the functions and what do these primary care clinicians do that's different than specialist physicians and specialist clinicians? The first is the whole person orientation, and we're familiar with that, taking the whole person into account. The second bullet is really about the fact that typically primary care is the first point of contact for someone who's experiencing new symptoms or concerns. So you don't need to go to a primary care doctor with a diagnosis. You can go to a primary care doctor with an ache or a concern or a symptom such as dizziness that's undifferentiated and needs to be fully explored and could be attached to any body system. Comprehensiveness is another unique quality of primary care. Primary care includes preventive services, so mammograms and colon cancer screenings, flu shots. It includes acute care, so those things that most people go to the doctor for, thinking about like a sprained ankle or a migraine headache. And then ongoing management of chronic and comorbid physical and behavioral health conditions. So people may have asthma or diabetes across the lifespan and need ongoing care. And behavioral health conditions such as depression and anxiety can also be an important part of the care that you receive from your primary care clinician. Primary care clinicians coordinate care for patients across the healthcare system, and they develop continuous trusting partnerships with patients over time. So these unique qualities of primary care make it different than something like getting a flu shot at a CVS or going to a specialist for a certain diagnosis or body concern. Next slide, please. High quality care, just as a reminder, happens in a variety of settings across California. California is unique in that it has long had the delegated model of healthcare, and there are large medical groups that care for patients. Kaiser alone cares for almost a quarter of the people of California. But we have to remember that about a third of all physicians in California are in solo practice, and California has nearly 1,000 FQHC sites. So we're seeing primary care delivered in a multitude of different kinds of locations, but ideally in neighborhoods where people live, so that the team has a more holistic view of the patient's experience, and the primary care team can know more about the patient and the structural, physical, social determinants of health. Next slide. So these unique qualities that we've discussed make high quality primary care the most fair, accessible, and cost-effective way for people, regardless of race, ethnicity, or income, to enter the healthcare system and obtain health services to meet their needs. And this is supported by decades of international and US studies. We are coming out, as Catherine mentioned, with a report linking high quality primary care to decreased disparities and improved health equity. And again, decades of research that established that link. So without universal access to high quality primary care, California is going to struggle to improve health and assure equity. Next slide. This is a survey conducted by for the California Healthcare Foundation in 2021 of Californians who have insurance, who have a primary care provider, and compared to those who do not have a primary care provider or a regular source of primary care. People with a primary care provider seek out and receive more physical health care. They're less likely to skip or defer care due to cost. They report fewer barriers to appropriate care, and they engage in positive health behaviors compared to those who don't have a primary care provider. Next slide. And here's results from the same study for Californians who do not have a primary care provider. And I want to call your attention to the second bullet here. Californians who have insurance but don't have a regular primary care provider have negative experiences with healthcare providers. They're more likely to have a doctor talk down to them, not listen or believe what they were saying, assume something about them without asking, suggest they were personally to blame for their symptoms or their health problem, and refuse a test or medication that the patient thought they needed. So definite benefits to having a primary care provider on top of having healthcare insurance. Go ahead, next slide. So we've made a lot of progress in California with health insurance coverage, but there's more to be done when it comes to access. 11.4 million Californians live in a designated primary care shortage area. So that's a little over a quarter of the people who live in California are living in areas where there is a primary care physician or clinician shortage. And a third of the primary care physicians in California are set to retire over the next decade. 1 in 5 California Latinx individuals still do not have a usual source of care, which is a proxy for a primary care physician or clinician. And access in the Medi-Cal program is particularly challenging. When we compare California statistics next to other states, we find that primary care access for children and adolescents is in the lowest quartile, and that participation by primary care physicians in the Medi-Cal program is second lowest in the country. Next slide. So we always like to think that money isn't everything and that it's not all about the money, but in many ways it is all about the money. We have not invested in primary care in a sufficient way in the country or in the state. More than half of office visits in the United States are to primary care clinicians, yet only 5% of total healthcare spending goes to primary care, which is low compared to other high income countries. The share of total healthcare spending on primary care is actually decreasing in a majority of states, including California. And then another way in which primary care suffers from a financial aspect is that primary care physicians earn 30% less than other physicians. And that makes it difficult for primary care physicians to build and sustain their practices. The average medical school debt is $250,000. So for a medical student to choose to go into a primary care specialty rather than some other area of medicine where they could make quite a bit more money is very difficult, and it makes it hard for us to build and sustain the workforce. Next slide. So primary care practices are in crisis. They've been chronically under-resourced, as we discussed. The overall spending on primary care has been low. Practices are continually asked to accomplish more. So this is something that, just to stay on the cutting edge of high quality primary care, we are asking primary care practices and clinicians to adopt electronic health records, completely appropriate and important to do, to have translators for their patients, to integrate behavioral health into their practice. A variety of different changes and adaptations that are having to happen that practices need to keep up with, and we're asking them to be accredited, and we're asking by, for example, the NCQA as patient-centered medical homes, we're asking for these various things, and it's a lot. They've been going through what we call transformation over the last 15 years or so, and the administrative burdens are high and complex for primary care, and especially in the Medi-Cal system, we know. And the way that primary care clinicians are paid for their services does not support the education that they do for patients, the coordination across the healthcare system, the development of relationships that are so important. So this problem's been brewing for decades. This is not new. Again, it's a chronically under-resourced issue. The workforce has now become beleaguered and burned out. We see burnout as higher in primary care than other specialties. Health professional students are not choosing primary care. That's true for nurse practitioners as it is for medical students. And these practices are in need of financial assistance, workforce, and technical assistance for all of this transformative change. And then we laid on top of this the COVID-19 pandemic, and practices were pushed to the brink, both financially, many of them had to close, visits stopped happening, fee-for-service payments stopped coming in. Next slide. And what we saw is that there was an immediate impact on health as well. So this is a slide showing routine childhood immunizations over time in the January, February, March, April period of 2020. And when on March 13, when the US national emergency was declared, we saw a drop off in childhood immunizations that was pretty dramatic. Next slide. And we saw this in mammograms and colonoscopies and other kinds of cancer screenings as well. So if our goal is to achieve the health system is to really improve access to care, right? We want to bring more people into the healthcare system. And as we work to do that in California, we also want to improve the quality of care for everyone and improve people's health outcomes. That's something we expect of our healthcare system. We want to decrease disparities, which is an effort unto itself that requires focused resources. And we want to do all of those things. So bring more people in, improve quality, reduce disparities, but we want to do it at lower cost. And the only way that we're going to be able to improve affordability at the same time that we're expanding the healthcare system and improving quality is to really focus on primary care. Next slide. These are the Department of Healthcare Services Comprehensive Quality Strategy BOLD goals for California. And I just wanted to call attention to the fact that these also are dependent on primary care. Well child visits and immunizations happen in primary care offices. Maternal and adolescent depression screening happens in primary care offices. Mental health coordination and follow-up and other children's preventive care happens in primary care. So we're not going to get to these goals unless we strengthen the primary care infrastructure in California. Next slide. Next bullet. So we need to increase primary care investment. Go ahead and release all the bullets here, which means spending more of the healthcare dollar on primary care. We need to modernize primary care payment models and mechanisms so that we get away from the fee-for-service model. And we need to expand and diversify the primary care workforce. These are sort of three big picture foci, I think, from a policy perspective that need emphasis and work. And fortunately, there's a lot going on in California with the new launch of the Office of Healthcare Affordability, with HCI's work on the health workforce. There's a lot going on, and we're going to hear about that from our panelists in just a minute. Next slide. Thank you very much for your time.
Thank you, Diane. You covered a lot of ground. Now I'd like to welcome our panelists to offer their reactions and their perspectives. We have a couple questions teed up, and then again, we'll move into audience Q&A a little bit later in the hour. So first, Pallav, why did the Department of Healthcare Services make prevention and primary care the foundation of its quality and equity agenda? What promise, very specifically, do you see primary care holding for California's Medi-Cal members?
I think it's really a twofold response. One is, as we look at our outcomes for our Medi-Cal members, we know in almost every single age group and category, we are seeing every single day preventable illness, chronic diseases that are severe upon presentation that could have been prevented with earlier engagement with primary care, with earlier diagnoses, advanced cancers. I am a primary care provider myself, and I think every single primary care provider who works in the safety net has those horror stories of patients who show up at your front door in your primary care practice that, had they shown up a year or two earlier, may have had a completely different health outcome. So I think we really see recentering primary care is critical to really changing the long-term health trajectory of our members. We are doing a lot at the state to really invest in our complex patient population through CalAIM, benefits like enhanced care management and community supports for our most complex individuals. But we also recognize our resources at some level are finite, and if we don't really think about the upstream intervention and prevention, we don't have enough of those resources for the most complex individuals. The second piece is really coming out of the COVID-19 public health emergency. A lot of the work that our health plans, our local public health departments, our members, our providers engaged in was really thinking about who has those trusting relationships to talk about COVID testing, COVID therapeutics, and COVID vaccinations with our members. And time again, primary care was at the top of that list. And we don't want to lose those lessons learned. You know, we know that a trusted provider that you have a longitudinal relationship with can really mean the difference between whether or not an individual is willing to engage in treatment and accept treatment, especially if they come from a group that has historically been marginalized and sometimes actively tested on by the medical community.
Okay, thank you. And can you share with us a couple strategies or tools or approaches you've used and some early successes to date, either to strengthen primary care or to increase investments in primary care?
So I'm really proud that with our state partners, with our new Medi-Cal contracts, which are launching in 2024, we have very universal, consistent language across us public purchasers to have our plans report on the percentage of primary care spend compared to total spend by plan, as well as to report on alternative payment models by plan. And so I think that's a huge leap forward to really be able to capture, where are we investing our healthcare dollars? Is it going to these upstream preventative interventions that we know are strategically aligned with where we want to go to? We also have been doing a lot of work on the provider front. So really excited that in partnership with the California Primary Care Association, our plans and federally qualified health centers in the state, in 2024, we are launching an FQHC alternative payment model to really enable this type of transformation and investment that we know needs to happen at our FQHCs across the state.
Terrific, thank you. So Alice, Cover California is one of California's most innovative and important purchasers and is often a model nationally. What are you doing to strengthen primary care, and what early successes would you lift up?
Thanks, Catherine, for having us on this panel. And full disclosure, like Pallav, I am a primary care internist by training, so I am completely biased. With that said, I think we're also evidence-based, and as an exchange, what is important to know is that a lot of people think, why is the health insurance exchange leaning into primary care? We believe what you said at the very beginning, which is primary care is the foundation of any high-functioning delivery system. And our work strengthening primary care can really be summed up as kind of the 3 M's: matching, money, and measures. And so I'll just touch briefly on each one. So for matching, given if you believe that primary care is kind of central to population health and everyone should have a primary care provider. And so since 2017, we've required that all of our health plans match at least 95% of enrollees to a PCP within 60 days of their first premium payment, regardless of if it's an HMO where it's pretty typical, or PPO or EPO. I will say, I wasn't here at the time, there was a lot of work with our plan partners, with our call center, with our enrollees, explaining to them that we weren't trying to create more barriers, or really, this was not the gatekeeper model, but that primary care really is that first contact, whole person navigation and coordination function. And what I'm happy to say is that roll forward several years, 99% of our enrollees per the health plan reporting are matched with the PCP. Want to underscore Pallav's comment about alignment. Really happy to also share that CalPERS has recently adopted a similar requirement based on our experience. And our next step is to do a deeper dive and figure out which enrollees are actively choosing a PCP versus those who are passively assigned, because we think that may be an indicator of engagement and may have an impact on utilization and quality. Money, we've talked about that. Money isn't everything, but it really does matter. And for us, the fundamental premise is that fee-for-service creates a hamster wheel that is incongruent to improving population health. And so we've had a long-standing requirement to increase the number of PCPs paid using what we call HCP land 3 and 4 categories, so shared savings or population health, PMPM capitation type payments, rather than fee-for-service. And over again, the last several years, the majority of our health plans have made considerable progress in moving away from complete fee-for-service, but we realize it's really imperfect. Because even if 100% of your PCPs are paid using HCP land 3 and 4, it doesn't actually account for the amount of money. So it could be just a little bit of the total compensation that is in these shared savings and population health payments. So we added a requirement, and this again is something that Pallav had alluded to earlier, where we require a reporting of primary care spend by HCP land category, as well as how much you're spending as part of total spend on primary care. We also asked our health plans to include visibility, because there is so much delegation in California, into the 5 largest primary care practices and how those practices pay their PCPs. The idea behind all of this additional kind of visibility is to figure out, again, hearkening back to what I think you had said about the Office of Healthcare Affordability, do we as a collective start to think about a floor or a target for primary care spend, knowing that there's a huge amount of variation out there? And then the last piece is measures. And the evolution here is that we had started off really promoting patient-centered medical home and realized that it was very process heavy. And in leaning into that for many years, decided that what we wanted to do is be less prescriptive and really focus on outcomes. And so we've done this on 2 parallel fronts. The first one is around the advanced primary care measure set, which we've done in partnership with IHA and PVGH's CQC. There's a pilot this year where all of our health plans are expected to collect a relatively small measure set that should be an indication of high functioning primary care. And the next step would be to analyze that and really use that data to both provide technical assistance to those practices that are not doing so well, but also over the long term, think about using that for contracting. And then the other piece is our quality transformation initiative, where we picked a very small set of measures, 6 to be exact, hand in hand with Department of Healthcare Services and CalPERS. These are measures that we think are epidemiologically important. If we all lean in together, will make a difference in terms of the actual health of Californians in hopefully a relatively short period of time. Blood pressure control, diabetes control, colorectal cancer screening, childhood immunizations. Importantly, we're stratifying them by race, ethnicity to have a clear equity lens, tying significant financial incentives. But then wrapping back around to what Diane said, they all live in primary care. So these really important population health measures in the end fall back on primary care to deliver on. So I just want to end by reinforcing kind of this thread that I've heard throughout, which is this need for alignment. In California, we are really fortunate to have leadership at so many of our public purchasers, our foundations, our conveners, our other state departments. And it feels like there really is this convergence on understanding the importance of primary care in terms of all these things, and particularly the money and the measurement piece.
Thank you. And a great reminder of really the power of transparency and of alignment. You brought up the topic of primary care spending. We've had several questions come in already on that, and I'm going to ask you to take one now, and we'll hold the rest to later. In your mind as a purchaser, where should the primary care spending target be? Where should it be set? And where does that money come from?
Well, I don't have the numbers off the top of my head, but we did partner with CHCF and Milbank, IHA, a number of others to do analysis of commercial spend in California. And if I remember correctly, the range was anywhere between 4.7 or 4.9 to almost 12%. So one thing is that there's a tremendous variation. And there was also a finding that the higher the spend in general, the better the outcomes in terms of quality. And so I don't have a magic number for you. It's not 13 or whatever the magic number is, but I think what we need to do is understand what the current state is, and then also learn from other states. There are other states that have actually set specific spending targets already, and then work collaboratively to raise the floor. Where the money comes from is a perennial question. I will say that given the stats that Diane shared, about 5% of total spend going to primary care, if we took a little bit from many of the other pots, I think we could figure out a way to augment primary care. It doesn't have to be a huge cut to everything, but I do think if we don't prioritize primary care, none of the evidence-based population health outcomes that we talked about before will happen.
Great, thank you. And for those that are interested more on that topic, Anne just put in the chat a link to the commercial study that Alice just mentioned that explored variation. We have another analysis of state spending and state target setting, and most states are in the 10 to 13% ballpark. Not to say that's necessarily the right range for California, but a useful sort of proof point. All right, Nina, I'd like to welcome you in. You are also a primary care provider and a health plan executive. So I'd like to hear what's motivating you both personally and Blue Shield organizationally to invest more in primary care and change the way primary care providers and teams are paid. And anything else you can share with us to help us understand what's being done to really improve things on the ground for patients, providers, and care teams.
So thank you so much for having me. It's an honor to be here. And I do think we have a little bit of a bias among the panelists towards primary care. I'm getting a sense of that. I love it that you asked what's my motivation to be doing this work now. I chose to go into primary care in the very early 90s. So in the immediate aftermath of the 1980s primary care gatekeeper situation. And so for me, primary care was always just like what was right in my heart. I just knew that it was the right way to practice, the right way for me to deliver care. And my experience since then of being a primary care doctor has really reinforced that. I love being a primary care doctor, and I love helping to improve the working environment in primary care, to make it a place where people can just adore having a career in primary care, and patients can really feel comfortable and at home getting care. So for me, the motivation's just been consistently there over the many years. For payers in general, I think are deeply motivated to figure out how to keep costs from spiraling upward without sacrificing the quality of care that's delivered. And of course, there's really good evidence, we've heard really good evidence, that strong primary care does result in controlled cost. Unfortunately, there's also really good evidence that we've dramatically underinvested in primary care for many years, and that has weakened our primary care system's ability to do that kind of service to our country. So the sticking point has really been how to do this. Like, what is the right way to reinvest in primary care so that we can get to those outcomes that we all, just naturally want to see? Multiple people have said this already, but we know that paying fee-for-service incentivizes office visits. People, do what they get paid for, and people need to see their clinicians. As payers, we don't want to stop people from seeing their clinicians, but this way of paying skirts such a huge strength of primary care, which is oriented to be able to respond to anything that comes up for any person, and by extension for the population, and that given whatever's coming up for the person, to be able to guide them to the right thing to do situationally. So to allow this kind of flexibility to respond, rather than just directing people to come in for another office visit, payment needs to not be completely tied to that fee-for-service office visit mentality. At Blue Shield, we've been thinking about 3 different levers that we can use to invest in primary care. Number one is attribution, which takes into account, that ties a member to a practice based on their patterns of where they go to get care. It makes that patient sticky to the practice. The second is risk adjustment, which takes into account diagnoses that make people more complex to take care of in primary care. And then the third are performance incentives, which reward outcomes. The thing about attribution is it allows us to pay a per member per month fee that provides stable and upfront income. And then that should allow practices to invest in the right kind of care based on what they know about their patient population needs. Risk adjustment really simply respects the time for primary care. Sicker people do need more care, they need more resources, and we should pay more for that. And then performance incentives, of course, support getting to good results, but someone else mentioned this earlier, without being really prescriptive about how physicians do it. It gives them the autonomy to figure out the right way to get to good. The other key thing motivating us at Blue Shield is the acknowledgement that we're in a complex ecosystem. I think this is interesting because I think once you admit you exist in an ecosystem, you can actually start to shift your perspective on what you want to do and how you might get there. So at Blue Shield, we know we can't invest in primary care by ourselves. And we also know that other payers are facing the same things that we are: rising costs, problems with access, including inequities, member dissatisfaction with the care they are getting, and then care that starts way too far down the line. Comprehensive, continuous, and relationship-based primary care can address those problems. So investing in it just makes sense for us. And I guess that gets us back to like, oh, it's the right thing to do. We should just do it. But like being in this ecosystem means we can't get to that end result alone. So we've supported the work that was mentioned earlier with the California Quality Collaborative and the Integrated Healthcare Association to convene multiple payers across the state to transform primary care payment to a value-based model that reduces costs and improves quality and equity. So at this point, in addition to us, we've got Aetna, Health Net, Oscar, and United Healthcare, along with Aledade, we've all signed a memo of understanding, committing to this effort to move to value-based payment for primary care through 2025. And we are continuing to invite in other payers and make it a welcoming environment for them to get involved as well. It's just exciting because we're the first state to have this kind of voluntary cooperation among payers ahead of regulatory requirement. So exciting times.
All right, thank you. Can I ask, what could other health plans do to shore up primary care statewide? You listed off your actions and some of your peers, but what do you hope for that others could do to help with some of the crisis points that we heard from Diane earlier?
One thing for sure is to get involved in the work with CQC and IHA. It's pretty inspiring work, and the more plans that come in, the better it's going to be for our primary care practices and for people throughout the state. I do think we can also expand who we include when we think about payers. Given the complexity of our healthcare system in California, large IPAs and health systems in many ways do function as payers. So we all need to work together to think about how we can invest in primary care to get to those outcomes that we want. I think the other one is around data and data sharing, because we really need to make it practical for primary care practices to be able to use data to understand their entire population, their whole panel. And this capability can't just be limited to large systems that have the resources to aggregate data. We need to be able to support independent practices with this same capability. And however we do it, we need that data flow needs to be bidirectional so that the practices can share with us data related to the quality of care that they know they're delivering. So those are two areas I think people could really work on right away.
And Allison Palloff, any other things on your wish list? What plans could do to help support primary care in California?
I can go first. So I think, certainly we know, and a lot of what the toll of the pandemic has taken on primary care practices, primary care providers were already burnt out. One of the really exciting things in Medi-Cal is how we are expanding the workforce. So we have added a community health worker benefit that is already live. We are adding doula services as a benefit, dyadic services, et cetera. And I think the only way forward is really to think about team-based care to both improve access, expand the workforce, and to offload the PCPs who've been bearing the burden of all of this work for far too long, and it's just not sustainable. But it's hard to go from day one to, the advanced future state where you're incorporating all these benefits, have the workflows, have the processes. And so we really see our plan partners as a critical piece of the puzzle in supporting our practices to leverage the new tools that we are making available at the state level. And then, as Nina mentioned, we have a complex environment. And so the more that plans can work together with that, so that it's not in silos with the providers who may be contracted with 5, 7, 10 plans, but really in a concerted fashion will be critical.
And I would build on that saying, in some ways, primary care and health plans are uniquely aligned in terms of population health, right? When you think about who could actually have an impact on population health, health plans get paid PMPM to take care of a group of patients, and primary care is that kind of preventive and upstream piece of the healthcare delivery system. And so for health plans, I think the unique role would be to really deeply understand the network and then figure out what the gaps are and then wrap around them, whether it's data, whether it's workforce, whether it's care management, giving the tools. I think that is a really critical role that we don't have. And again, this very complex ecosystem of ours. And some practices, large IPs, will have it all already. And you don't need to do much. And you basically, take a little bit of admin and you just let them go. Others you're going to really have to bolster, and figuring out the not one size fits all, but figuring out how you actually deeply understand your provider group, because that's where care happens, that's where quality happens, that's where equity happens, like on the front lines. And how do you support that best? That's what I would love to see all health plans move towards.
Great. Thank you. All right, well, let's welcome Anthony into the conversation. There you go. Hello. So the new Office of Healthcare Affordability will have authority for tracking and reporting spending on primary care and ultimately setting a primary care spending or investment target. And that's clearly a step in the right direction. What do you think we as primary care champions can do to assure that all healthcare stakeholders are sort of rowing together in support of this call to revitalize primary care? What more is needed, and where would you direct our attention?
Yeah, I'm excited about the efforts that have been just described over the course of this call. The alignment between payers, whether it be public payers like CalPERS Cover California, Medi-Cal, or private payers like many of the health plans. But this works better if they're all working under the same rubric toward a similar goal. And that, I think, is what the Office of Healthcare Affordability can provide. When those of us who advocated for the office were thinking about it, we have a lot of agencies that work on different parts of the health system that, with regard to Medi-Cal, with regard to the individual market, with regard to managed care. But the office will have the unique ability to look at the health system as a whole and to set broad targets and goals. And clearly, first and foremost, that is about affordability. But I think the goal of the office was not just to provide a target and a goal, and it's important to set those goals. You can never reach a goal that you don't set, but it's also that we want to provide the industry tools to meet those goals, as well as accountability to make sure that they get there. And having a tool of a primary care target so that the various players in the industry can align and they're all being judged and have some accountability toward that will help that alignment happen. And I think that that's really important. I also do think that the focus on primary care is important for this overall goal of affordability, which we hear consumers and Californians crying out for. The issue of affordability has been underlined in so many areas of life in California, in a high cost of living state, but it's been for decades in the world of healthcare. And there is evidence that the more we can invest in primary care, the more that we can get to that more efficient, effective, and ultimately cost benefiting system, that a system that tries to contain costs better. And I think that that's important. And I see that as important for why I'm happy to be part of this conversation, because at the end of the day, when consumers think about the healthcare system and the problem in the healthcare system, they don't necessarily talk about it in the way of like, we need more primary care, right? For some, it's basic and foundational as their experience. For others, as Alice said, some might see primary care in their own way as a gatekeeper, and the gatekeeper role that sometimes the primary care physician has in a health plan structure. But from our point of view, it's a tool to get to the goals that consumers are demanding, whether it is better quality, better outcomes, whether it's health equity. and reducing racial and ethnic disparities, whether it is the issue of affordability, or fundamentally whether it's this question, which was also came out in the research of consumer experience, of that this is a very complicated healthcare system for people to navigate, and you need and having a strong primary care structure helps. Having somebody as their advocate within the healthcare system, as their home base, as their place where which is more attached to them and their community, knows their needs, can help them, so that the health system doesn't have to be as Kafka-esque as it is for so many. So I am very excited. Excited about these various goals, and I think the Office of Healthcare Affordability is one of those things, and there's other things as well that we can be doing to move in those directions, not just primary care for its sake, but toward these broader goals that consumers are demanding.
Thank you. And I love that image of home base. So you talked about affordability, you talked about better experiences, you talked about having someone who can help navigate the healthcare system, or as we heard earlier, the healthcare ecosystem. Are there other specific things you think consumers want and need and find value in that primary care can deliver?
I mean, I think they would, I talked about some of those, and frankly, first of all, we need to get people in the system. And when we, as a consumer advocates, argue for the further expansion of healthcare, including bringing in hundreds of thousands of folks into Medi-Cal who were excluded because of their immigration status, that is actually an argument. Our argument and our desire is for them to have access to primary and preventive care. There are venues for them to get emergency care, but in the most expensive, least effective way possible, of emergency rooms and the like. What we wanted to do is expand primary, preventive, comprehensive care. These folks are in our system. They were just in the least effective, most expensive way possible, and so providing that primary care. But for those who are in coverage, it's not entirely clear that they are in sort of a system that values and centers primary care as a place where people can get both that sort of preventive care in the front end, and, as was described earlier, that care coordination, whether it's managing asthma, diabetes, those kinds of issues, which are preventative in a way, that do make sure that people have the basis to continue to live their life. So it is I think it's different in our fragmented system. It's very different in different ways. I think what we need to do, and the office is the beginning of it, is that I do think that the issue is that the lack of investment in primary care is a tool to move forward, but it's also a symptom of the misaligned financial incentives in our healthcare system, where we're not necessarily putting our dollars where we can get the most bang for buck. And so can we create structures like the Office of Healthcare Affordability and others to straighten out those incentives for and to move a lot of different payers, a lot of different fragmented pieces in the right direction. And the office is a piece of it. I think there are other things that we can continue to talk about, and I know that's part of the discussion of what we're doing here today and going forward.
Great, thank you. Primary care, the way back home. All right, Diane, I want to give you a minute to react. You've had a chance now to hear from our panelists about their perspectives. Anything more you'd like to add to the conversation?
I'm just so grateful for all the work that's going on in so many different corners of California, and the reaching the alignment that's happening within these different areas. So across for purchasers and payers and people thinking about the workforce. I really appreciate the work that's going on and the momentum that I think we have. I just want to call out the National Academy of Science, Engineering, and Medicine came out last year with a report on primary care, the first one they've come out with in 25 years, focusing on primary care. And it's a national blueprint for really strengthening primary care. And I think it's served as a real resource for us to think about where are we compared to what the recommendations are nationally. And I think California is in a great position to lead with many of the different initiatives that you've heard here. A couple of the recommendations that came out in that report for the federal government was to have what is now happening. It's a new primary care initiative at the federal level. And now there's a call for an office of primary care at the federal level, but really to have somebody wake up every morning and think about primary care and in the federal government. And I would like to see something like that happen in California, where whether it's within the new Office of Healthcare Affordability, whether it's within the governor's office, or whether it's some kind of private forum, I would like to see a holistic thinking across all silos and disciplines about primary care, because I just think we're at a point where we have the momentum. And the other recommendation that came out of the federal effort is to have a scorecard for accountability, and it's a policy scorecard to say, how are we doing with regard to these recommendations? And then of course you need someone or some organizations or people to hold accountable. And it would just be really great in California to see that increased accountability now that we have so much going on, to be able to track over time and be able to say, this is how far we've come and this is where we still want to go. So those are just a few thoughts about what we're doing relative to national. And I think there's some people on the line who are from across the country and from the federal initiative who are looking to California to see how we're leading. And I'm certainly looking to places like Virginia that has a governor's task force on primary care, and other places across the country that are got out of the gates early with some of this.
Yeah, and I think that's an important reminder. You gave us California-focused statistics to start for this session, but all of the issues and all of the challenges that you noted are really national in their magnitude. Yesterday, the Agency for Healthcare Research and Quality, for example, released their 20th National Quality and Equity Report and found that 60% of counties across the United States have a shortage of primary care healthcare professionals, not just physicians, but the whole primary care team. So a widespread issue. All right, well, let's move into our Q&A session. Again, please type your questions into the Q&A box. We've already gotten quite a few, and several themes are emerging, so I will also lump where I can. Our first question, and I'm going to ask Nina to start with this one, is how we see the emergence of what's called non-independent or non-system aligned primary care providers, groups like CVS or Health Hubs, Amazon, One Health, etc., playing into this new primary care landscape. Are they the future? What are their limits? How do you think about them and their ability to provide high quality primary care?
It worries me. I mean, I'll be honest. I think that the proliferation of solutions that provide access without continuity creates a real problem. So I suspect what's going to happen is that will happen for a while until we start to see the data on the outcomes that are happening as a result of these of the care that's being delivered there, that we aren't getting control of blood pressure, we're not getting people immunized, and then we'll start to figure out how to pull them in. Ultimately, that ecosystem analogy for me, we know that we're all related, and that even though these upstarts, these urgent care only sites are providing a service that people need, we're all going to have to pick up the pieces. So we're going to have to figure out how to do it together. I'd love to know if other people on the panel have ideas about how we can rope them in sooner.
Can I jump in here?
Please go ahead.
I think just, and this is where a group like an Office of Primary Care within the Office of Healthcare Affordability really could have some purview on something like this. But I think this is the truth. we have a severe primary care workforce shortage. We're not going to be able to recruit and train enough people to take care of the needs of the population. So it feels to me like there are all these quote unquote innovations bubbling up, which frankly could be used for, I don't want to be dramatic about it, evil or good, could be used for integration or fragmentation. And so I think to Nina's point, a lot of it does drive towards fragmentation if you don't put guardrails on it. Because I still remember when the first Minute clinics came up, traditional primary care is not great about access. It's 8 to 5, no weekend, and so I thought like, wow, couldn't those be the foyer into the patient-centered medical home? And they could be if there were the right systems, requirements, expectations, measurements, and accountability in place. And so that's not going to happen through the market. I think that does have to happen through some, other oversight to put up the guardrails to say, yes, we'll let these innovations flourish, but only if they are part of the longitudinal comprehensive picture, because what we don't need is more fragmentation and additive services as opposed to substitutive or synergistic services.
Yeah, I mean, I would just underline that I think it speaks to the sort of the hunger out there for a system that is actually aligned with consumers' needs, and including convenience in terms of geography, in terms of time, in terms of how people live their lives, and when they are available to do things. But I am, skeptical, because the way these decisions are generally made it's more about a real estate transaction. It's more about loss leader to get foot traffic into certain aisles into the store, more than necessarily about trying to provide a continuous medical home for folks. And the question is, how can we have a system that actually does provide that? Because if the system as it exists, the health system as it exists doesn't provide it, then there will be other things that will be happy to try to make a buck, filling in gaps. And that's that's what we have to respond to. But I think there is a way to address that, but we want to make sure that, at the end of the day, there are some things that can be done, quick and easy, but there's a lot of things that that you want some longitudinal continuity of care. You want some level of expertise, and you also, want consumer protections and patient protections to be in place when things inevitably go wrong.
Can I say, I think an important way to enable that to work well is data sharing. That I think if there's collection of data and obligation of anyone who delivers care to deliver that data into a centralized place, that's the way we'll be able to see what's happening. So I do think that might be a very, very important place to focus. And I don't want to downplay the importance of access. I think of so many patients I've seen who came in because they thought they had a sinus infection, and it turned out they were in atrial fibrillation. And we never would have found that dangerous arrhythmia if they hadn't just come in for the simple thing that they were presenting with. So it is really important.
Do you mind if I want you to be able to move on to your next question, but just in terms of the technology piece, and I am a total proponent of data exchange, data sharing. It is foundational, and it's necessary but not sufficient. And I think oftentimes we anchor on technology. I saw this with EHRs, and now I fear we're doing it with HIEs. It's going to be the magic bullet. It is not the magic bullet. Processes and people are foundational to primary care. And so basically what we saw with EHRs, if you have crappy processes and then you electronicize it, you have crappy data moving at the speed of light. So I think you really have to attend to some of the non-sexy, non-plug and play stuff in primary care if you really want it to work. And I then do want to emphasize Anthony's point, which is in the primary care world, we are so beleaguered, and we are the kind of willing to do the right thing. I'd always been this proponent for primary care for the underserved, and realized, most primary care providers actually are like caring for the underserved. It's just, we end up being so beleaguered that we oftentimes talk about ourselves, or we think about like the things that are our barriers, as opposed to figuring out, how do we really meet patient needs, which include 24/7 access, and include, being able to to get the right level of care and not a one size fits all. So I do think we need to think a little bit outside the box on that also. Sorry, that was two different comments put together.
And I think sometimes we wait for that disruptive innovation to come. I mean, I agree with others who say, you know, the Minute Clinics were supposed to be the disruptive innovation in primary care. So many and video visits at the beginning of the pandemic were, you know, oh, primary care is solved because now we have video visits, and video visits is one way to access primary care, but a video visit doesn't necessarily, it's not the same. I don't know. I think we sometimes confuse convenience with and solutions to how do I get a strep throat test, or how do I get an immunization, how do I get a one-off thing for a UTI, with true primary care, which is really people who have multiple things going on at once, who don't know what their diagnosis is, who need help sorting through that, and who benefit from someone who knows them, who can advocate for them and help them navigate through a complicated healthcare system.
And provide that comprehensive care you spoke about earlier. All right, another theme that's come up is sustainability. Given the upcoming recession, some disappointing budget forecast news, the state's disinclination to raise Medi-Cal rates. What does this all mean? How are we going to get more resources into primary care? What's needed, and where are these resources going to come from?
I can start. So, you know, obviously, I think recessions are tough all around, and we see during recessions, the number of people who end up on Medi-Cal obviously is projected to grow, and that has its own strains in the system. I think when it comes to rates, obviously, there are complicated factors here, because what the fee-for-service published rate is not necessarily the rate that is being paid in Medi-Cal managed care, nor does it include, you know, we have numerous supplemental payment streams, which is one of the things that makes California quite complex at the provider level. All of those caveats being set aside, I do think that the sort of renewed emphasis on primary care and requirements around primary care, at least from Medi-Cal, if you read our population health management strategy and roadmap, all of the new requirements in that population health program that our plans will have to meet come January 1, 2023, there is no way to meet them that does not go through primary care. And the plans have a lot of flexibility. So as they look at their network adequacy, as they look at access and capacity, they absolutely can pay more to primary care providers in order to meet those needs. So I think that is one of the levers that we are absolutely pulling on at the state level, and utilizing the managed care flexibilities that we have. And by 2024, 99% of all Medi-Cal beneficiaries will be enrolled through managed care, which means that sort of, you know, the number of reimbursements happening on that fee-for-service publicly available fee schedule is, you know, 1% of our population, which really underscores how important that relationship and that contracting process between managed care and the primary care providers is.
Other thoughts?
Yeah, I would just want to say that I don't see this as necessarily the zero-sum game, you know, kind of situation. You know, the metric of, you know, what is your percentage of your overall spend that is primary care is sort of an important metric, but sort of a blunt one, and not. And I want to you know, say that in an ideal world, part of that increase in that percentage comes from the fact that you are investing in primary care, which also then means that more people are taken care of in the front end and not in necessarily the more expensive back end. And then by dint of percentages, then that you have the primary care because people are being taken care of, and so that you don't need as much of the more expensive interventions in the back end. Now, obviously, there's a chicken and egg question here of, you know, the upfront investment to sort of to get that return on investment, but there is sort of a circular impact where that if the system is working well, then that percentage should rise, and as part of this effort. And the question is, do we have the incentives and the fact that if different payers and parts of the industry are doing this aligned and not trying to and doing it in a way so that they're not being seen as they're not being disadvantaged for doing anything in this direction, then I think we can get there. But so I just want to, it's not necessarily sort of a zero-sum game, and I want to just underline that as we think about how we do this within both the commercial payer world as well as in Medi-Cal, as Palau was talking about.
I think this is a little bit of a reprise of the previous question you had asked about, what should the target be and where does the money come from? And that, again, is always the perennial question. It is really hard to move resources, and that's where I think some of this understanding where we are, the transparency of spend, but also I think a lot of the federal rules on cost transparency for both hospitals and health plans are going to be really interesting, and not because they're going to be consumer friendly, because honestly, I think there's plenty of data to show that consumers really aren't in a position for a variety of reasons to really shop based on cost in a really robust way. But I do think having that transparency around variation of prices for hospitals and for health plans will reveal a market failure, which creates an opening for more to have some rationalization of where the spend happens.
Right. So Diane, you noted in the presentation that it is not just about primary care providers or clinicians, but really thinking holistically about the primary care team. We've gotten several reactions to that and several questions. So one, and I'll put this out to the group as a whole, who should be on the primary care team of the future? And how do we bring them into the fold? What type of licensing changes might be needed? And what type of training supports do we need?
I'll just start by saying I don't think that we have decided exactly what the perfect primary care team in all settings is. I think that there are different models and they work in different settings. I think that what we do know is that connecting primary care to public health, for example, connecting primary care to community, for example, providing that coordinating role in primary care, integrating behavioral health into primary care, that those things lead to better health outcomes and better equity. And so the kinds of people who can help, like community health workers who come from the community, who know the community, and who can bring lived experience to a relationship with a patient or with a population, is going to be really important. And there's some movement at the state to really build out the community health worker workforce. There's a lot to be learned, though. For example, in the behavioral health, we know we have a real behavioral health shortage in terms of workforce in California. And if anything, the demand for behavioral health has gone up in recent years for a variety of reasons. And finding the right workers to deliver that care is going to be important. And there's this new role of coach, and there's a lot of discussion around, well, what does that mean? And how do we certify, or how do we train? And who are we sending out to spend time with young people to help them with their behavioral health issues? So these aren't simple questions to answer, I don't think. I am pleased that California is exploring options and investing in workforce and especially in the primary care workforce to help begin to solve this. But we're not there in terms of knowing. I don't think we can say, for example, there are physicians who work in solo practice. How do they bring in a coordinator, or who do they bring in to help with pharmacy, or how do they partner with behavioral health, and how do we share resources to help support those solo doctors or small group practices? And that team may look different than a team in a large health system or in a federally qualified health center. And the payment for the team is really what drives a lot of that. I think what's most important is that these things are integrated at the practice level, and that there isn't some, dial a nurse over here or dial a doc over there or whatever, that you're getting someone who doesn't know you and doesn't know you in the context of your true primary care relationships. I think having these things integrated at the practice is going to be important.
I echo what you said, Diana. I think, you can name a bunch of different professions that should be on a team. It may be more important to define what functions should happen in primary care, and that those functions can be performed by different people depending on the specific setting. I think one thing that should be part of the primary care team that often isn't thought of, and this is a relatively novel concept to me, is the idea of e-consults in primary care, which brings the specialist into primary care in service of the primary care clinician's role. So I think it's a piece that we should be thinking of. It's actually accessible to us now. It is a technology-enabled solution, but it's sort of like, it's an easy one. And it broadens the scope of what primary care can do by allowing them to kind of phone a friend in the form of a specialist. So that seems like an important one for us to be thinking about.
All right, and here's one I'm going to ask Anthony to start with. A note that it's been challenging to get consumer groups to engage in issues around market dynamics. What ideas or advice do you have for ways to get consumers involved in pushing for a change in the way we pay for primary care?
Yeah, I mean, if you start off and saying we want to change the way that we pay for primary care, you're not going to get a lot of grassroots attention, because you're already like 3 steps down the rabbit hole of people are interested in their experience in the healthcare system, how providers are paid, and much less the sort of the inequities and the incentives that exist within them is a level of detail that, frankly, I've spent 20 years working on this, and it's confounding to me. I would say, but I think you need to start with consumers where they are and what their experience is. And I think folks know that the healthcare, that people are deeply grateful for the healthcare that they get. It is core to the sustaining themselves and their family. And so, but they also appreciate, everybody has their own story about how crazy making it is trying to navigate our system. How I think, I was on the Healthy California for All Commission, and some of our findings in the research that was commissioned for that talked about how one of the biggest experiences that people have in our healthcare system is, one is waiting, but number 2 is just feeling disempowered, that being in a healthcare system feels disempowering. And the question is, can we get to a system where folks can get the care they need, that don't have huge financial incentives to do that can have good outcomes, and where they can feel respected? And if we can do, and I think that primary care is fundamental to that. And so, to the extent that we say these are the tools, and this is the way that we can get to those goals, then you have engagement by consumers and the sort of those of us who are advocates or organizations, with those constituencies to try to advance that forward. But it's, you have to start with with where folks are, with their experiences, and then how would this impact their experiences, and then we can get to this. I do think that people understand that right now we have a system where the financial incentives are not necessarily toward the best quality consumer experience, even the best outcomes. It's more about, the market share of given payers. It's more about, 5 other things. And that's why we have such a disinvestment in primary care. It's the certain sort of market mechanisms that have just led to a over focus on specialization, underinvestment in primary care, and that's why we need some disruptions like the Office of Healthcare Affordability to try to create some sort of global goals and practices, and that's our hope for going forward.
Great. So we heard earlier about some of the efforts to support safety net practices. Federally qualified health centers will have the option to participate in the alternative payment methodology. We've had a couple questions come in about private practices, noting that private practices are on razor-thin margins. What are the state agency or health plan obligations to invest in practice transformation so those primary care practices can deliver high quality primary care and help our state reduce health disparities?
I feel like maybe I should start with that one. I tried to touch on this earlier. I do think we have an obligation to support independent private practice. These are folks who are persisting in their communities, who often are the only practice in a large area, who do really know their community because they're part of it. And yet they don't have the resources both to manage their practices day to day, but also to negotiate with the health plans for the rates that larger systems can get. And so there's a lot of unfairness that gets introduced into that. So I think one way we can do it is by directly redesigning the way we pay those practices to give them the financial advantages that large systems who've negotiated for higher rates can get. And that's by investing in primary care through some of the mechanisms that I was talking about earlier, through payment for attribution for those patients who stay sticky to those practices, payment for risk adjustment. They are often taking care of really sick patients, sometimes without access to specialists. So they're taking care of conditions that we would normally think of as ones that are, that patients would normally see specialists for. And then through their performance, right? Like when they get great results, they should be rewarded for that. So really just bringing financial investment to bear to those practices is one thing. And then I do think the other thing is data. They don't often have resources to invest in systems that will allow them to know their whole population and to see where they can put their efforts to make that population healthier. And that's a place where I feel like we all as a group have to figure out how to aggregate data for those practices so that they're not logging into 10, 12, 15 different portals to try to look up where their care gaps are for colon cancer screening or when they've last screened someone for an annual checkup.
Any other thoughts on that topic, Alice?
Yeah, I would add, I think we have a really good understanding of the formal safety net, particularly the FQHCs. I think it would be really helpful to have a better understanding of kind of the non-formal safety net primary care network across California, because there's a huge the tagline of healthcare is variation. Like no matter what part of it you look at, there's variation. And so there are great practices, there are not such great practices. And I'll say, having worked in the safety in my entire career, there are FQHCs that are really able to do process improvement and innovation and take advantage of whatever resources are given them. And there's some that aren't, and so in our quote unquote market-based system in the United States, we have to figure out where do we need to invest responsibly in a way that like the groups that really do need the help, but then there is some accountability to actually deliver on that. So I do think data infrastructure is huge. Actually, other care processes, again, harkening back to the role of the health plan to really understand that, for health plans to understand their network, but for the state to understand the primary care network of the state and figure out where to target those investments. But hand in hand with those investments needs to come accountability. So both like you get the additional resources and here are the outcome measures that we expect. And again, with the understanding that you need to risk adjust not only for medical conditions, but for social drivers of health. It is harder to move someone's A1C if they're marginally housed and food insecure. And if you're given the extra resources to do it, there has to be some accountability for improving that outcome.
Got it. Thank you. All right, so we've had...
I was going to say, just to piggyback off of Alice to underscore the point, we, especially in California, are such a broad and diverse state. And I think increasingly, especially as we've expanded coverage, our systems are not as segregated as they used to be. So yes, we still have provider types, federally qualified health centers disproportionately serving Medi-Cal members. But we also know that, 60 to 70% of our population gets their primary care outside of federally qualified health centers. And then those practices, what they really need is sort of multi-payer alignment and the sort of responsible investment that Alice is talking about.
All right, so for our last question, we've heard some tremendous examples today of state action and calls for state action. This is a question about federal action. What is needed from the federal government to facilitate primary care workforce development?
Well, I'll take a stab at this one. I mean, you know, the federal government supports the training of physicians as residents, and there's no reason that it shouldn't support the training of other professions that are needed in primary care. There's many young people who are eager to have careers that have meaning, that serve their own communities or serve other communities that are in need, and they often don't know the pathway to get in, or they don't have the mentors or sponsors to get them there. So it does feel like training and support opportunities, particularly for people who come from underrepresented communities in medicine currently, would be a huge thing that the federal government could do. I'm sure other folks have much better ideas, but that's the one that really leaps to my mind from my experience and like trying to bring students into my practice and mentor them and seeing the effect that that can have.
Other ideas?
I mean, of our $400 billion healthcare system, $250 billion of it is federal. So, you know, it is. It's a payer, and obviously some of those dollars come through some of these state dollars, like Medi-Cal, like Covered California. But the bulk of that comes through Medicare, which is largely, if you're going to do something in the Medicare space, you know, it has to be done at the federal level, and that's a whole swath of our healthcare, at a disproportional swath of our healthcare system when you're talking about seniors and people with disabilities who probably use. You know, obviously use healthcare more than other parts of the population, and so I think having the leadership of the federal government matters, but also having those dollars, having those systems, similarly put in place some of the things that we're starting to in California. We have a long way to go, but starting to with regard to making this a priority, setting goals, aligning systems in this regard. I would also just be remiss if there's also an opportunity at the federal level with regard to private payers, since there's a good portion of the payers are employers who are multi-state employers covered under ERISA. So that's another area where you need to have some alignment, and some leadership at the federal level helps. And then at the federal level, you can. I do think that the focus on equity, which, you know, we talked a lot about, but you can never talk too much about it. About how do you do this in a way where it's at the primary care level that you have the opportunity to sort of really focus in, not so much on the specialty of the doctor, but on the community that you're serving, whether it is like whether it's a Latino population or an LGBTQ population or people with disabilities, and have people who can specialize in a community and in serving a community. And what does that mean? Sometimes that means having lived experience, sometimes just being embedded in the community. And some of those guidelines can be done at the state level, but can be better done at the federal level, because you're looking at the broader population of the United States. So those are just some initial thoughts.
Terrific. Oh, Diane?
I'll just say that you know, the primary care extension service, I always like to give a plug, was authorized but not funded under the ACA. And, you know, there are ideas such as that, but the idea being that across the country, much like the agricultural extension services, that you could put hubs in communities that would support primary care practices of all ilk, and share resources and share data and share technical assistance and these kinds of things, so that there would be more of a community-based center where public health could be integrated more easily, or where resources could be shared more easily, or where data could be shared more easily. So there's, and then anything that Medicare does, sort of, where Medicare goes, that's where commercial insurance and others go. So, paying for other members, for services for other members of the primary care team, and helping to fund the kinds of research we need to better understand what works and what doesn't in terms of teams. When I'm just thinking about workforce, those are some of the things that come to mind.
Very good. All right. Well, we need to wrap up. I want to offer my thanks to the panelists today. You all have provided really incredible information, perspectives, stories, and examples, both of why primary care matters to California and how we can help expand it, rebuild it, strengthen it, revitalize it. Pick your word, but it needs help, and it needs help now. So thank you for that. We weren't able to get to all of the questions today. There were some very technical ones, but we'll follow up with many of you individually to get you answers and resources that you requested. Again, the recording for this session and the slide deck will be available right after Thanksgiving on the CHCF events page. It'll also be emailed to you. Please do take a moment to complete the survey that's in the chat box here to give us your feedback on this session and your ideas for future sessions. And thanks to all of you for your interest in this in the topic and for your efforts to improve care for Californians. Thank you and take care.
Thank you.